Sorry.
All right. Well, this is the first Facebook Live conversation. Thank you, Debjani, for joining me today. My name is Shanaz. I'm from South Africa, and South Africa is one of these countries that is one of the most unequal countries in the world, and we have so many, devastating levels of inequality in the country. And we're trying to address these inequities as we as we aim quite ambitiously towards universal health coverage. And we're also one of these countries where our rates of gender inequality and gender-based violence is incredibly high. And we're here in this conference where the theme is really about moving towards health for all, leaving no one behind. So I'd like to first start by asking you to tell us a little bit about yourself.
Hi, I'm Debjani Burman from IIHMR University, and I'm working in Indian Sundarbans. It's situated in the Ganga, Brahmaputra and Meghna Delta, and part of it lies with our neighboring country Bangladesh, and 40% of the Sundarban is with India. So I'm working there on their health systems, health-seeking behavior for the mother and child over the last 10 years. And it's a group of islands, intersects with tidal creeks and estuaries, making them divided into a piece of lands. So it's a very high geographical inaccessible region. The issue of inaccessibility is very high, and it also have a suboptimal presence of health systems. By suboptimal, what I wish to mean is that formal sector is there, but it's leaving a whole lot of people behind because it's available only up to a secondary level. At primary level, preventive health service is there, but again, it's functioning. It's more focused on the preventive health care. So this is all about me.
Thank you for sharing this about you. But I think what's interesting about what you say is that when we talk about universal health coverage, we talk about having services available. But that services available doesn't necessarily translate into services that are accessible.
True.
And there are many barriers to accessing services.
Exactly.
Maybe you can highlight some of these barriers.
I will certainly say that number one is geographical accessibility for Sundarbans, and there is an issue of acceptability also. And in my recent past, I did a study on usual intersectionality lens. It was on eye visual impairments with the elderly of Indian Sundarbans, and there I tried to find what are the social determinants and how gender cross-cuts with these various social determinants to decide the eye health status and a high health care seeking behavior of the elderly of Indian Sundarbans.
Okay. I'm glad you brought up this concept of intersectionality because it's something I'm also quite interested in. But can you explain the concept to us and maybe just give us a bit of using the case study that you described? Apply it.
Yeah. I will start the example with me and you. Just for example, I am a woman, a married woman, Hindu married woman, working, educated, obviously, and with a girl child at home. So I'm here in this forum because I have a supporting family back in my home. My husband is ready to take care of my daughter. So my identity is just multidimensional. It's not a single dimension. So intersectionality actually brings this various dimensions or the multi-layered level of vulnerability into a single place. Earlier we used to do this equity analysis or any analysis in a single place. But I think intersectionality brings us that opportunity that a single individual is just not a male or a female or an elderly or a young person. There are various dimensions into your identity. So intersectionality gives you that freedom or that point of, I would say that it's a good opportunity to cross cuts and see which dimensions is your embedding factor, which is your facilitating factors.
Okay. I mean, I think you one of the elements of intersectionality is really thinking about your positionality
Yes.
too. You know,
Yes.
and you've clearly stated that positionality is quite varied depending on your education, your support system, and other elements. I'd like to know maybe in your study if you can share some of the research methods you used, because to me intersectionality can be an interesting tool to identify, but unless it's really used to push or drive research that brings greater equity, I'm not sure how we can use this concept, you know.
Yes, true.
And in a sense also, I want you to maybe reflect, we're thinking about alma ata and primary health care. There's no intersectionality in alma ata. So what is your reflection on those two things?
First, from my study, what I would like to say that it was a mixed method study. So I did a quantitative data collection cross-sectional study, and then that is complemented by qualitative in-depth interviews of the visually impaired elderly, both male and female there. The striking difference that really I would like to share with you is that I found that even a non-poor female has a lesser access to eye health care compared to a poor male. So just being non-poor, that means I'm a rich woman, but that doesn't ensure your access to healthcare. Then it's come to our mind that it is the issue of mobility. In our community, the women, they hardly travel alone. And once you are aged, your mobility is limited within your households.
Okay.
So going to a health center or the high-level hospitals, you always need an accompany. And mostly, it needs to be a male. Whereas, even a poor male, he can easily decide where to go, when to go, so he can move away of his own. So that I really found very interesting, and only the intersectionality actually helps me to get into this analysis. Coming to alma ata, I really think it's time that, since our target is not to leave anyone behind, a single approach, we always prefer just a single policy implications, a single solution for everything, but it's not possible. You really need to be contextualize your policy, and it is very necessary that it comes from the community. So it's very much need to be embedded in the community, and from that your policy recommendations should come, and on top of that it should be consider all these various dimensions of vulnerability, not a single one, just not a gender lens, just not an economic equity analysis. It should be intersecting with all these things that determine one's access to healthcare. So that's my opinion.
That's a really interesting way of thinking about how to, you know, rethink perhaps the Alma Ata Declaration and really not just mention community participation or mention vulnerability, but to do so in a more nuanced and a detailed way. But I want to pick up one of the two things that you spoke about in your example. You alluded to a gendered experience of access to healthcare. For a rich woman, it was not clear whether she could access care, but a very poor man perhaps had more agency to go. So it makes me think about patriarchy as a big dimension that is something that we need to consider. And again, I want you to maybe ask, reflect on how do we, in health systems research, get to some of these power structures that dominate, because to me it seems like we're still avoiding them.
True, absolutely true. Because in what we made while analyzing this data more into the qualitative analysis, what we found that many of these women, they're widow, so all the properties are in their own name, but she doesn't have any freedom to decide on what to make use, or for what to use those resources, and when. So she always depend on her son to take the decision, and even if she report that yes, I am suffering from visual impairments, there is always a delay on the part of treatment seeking, because it's always at the convenience of someone else than when can she actually go to the facility. So I really think it's on the part of the supply side also need to come to this woman clearly. So we found that there are certain camps in their localities. So they used to go there, get checked by the doctors available in the camps, but they're a bit reluctant once their visual impairments is identified in those camps. They're a bit reluctant to go to the high-level facility for the better treatment. Perhaps she needs a cataract operation. So she's a bit reluctant in leaving her home, because she's again responsible for all the household jobs. So we'll take care for that. So such things are there. So this power dynamics is very much important to be considered in any policy formulation or any program delivery, I think.
And if you had to give something practical about how we can do that
Yes.
at different levels of government, or at least I think sometimes even on a global and an international level, what would you suggest that would actually, speak to the needs of these women that you describe and these men with visual impairment that you describe?
I think more and more women into the leadership can ensure that, like you, like me, we are doing the research in the gender and using the gender lens. So we are generating scientific evidence how gender lens is cross-cutting with other social determinants. So if we keep on generating more and more evidence, and there are some female in this policy lead position, in India there are certain Gram Panchayat level administrative people there. They are female. The idea was initially that once she is a female, that it was aimed to feminization of that local governance system. But what actually it ended is, most of the time she is the wife of the earlier male panchayat head. So yeah, but it started. At least it has started. So we have to give some time to them as well. And there is a lack of capacity building also on the part of this woman.
I mean, you bring up an interesting contradiction, because you're saying that one of your suggestions is having more women in leadership.
Yes.
But then at the same time, you're recognizing that sometimes these women are strategic choices.
Yes.
But there's a male that's standing behind them.
Yeah.
So to me, again, I think when we think of the power structures like patriarchy, I'm not convinced that women are not agents of patriarchy as well. So some women carry that,
Yeah.
in some ways even more strongly than males would.
Yes.
So to me, women in leadership is definitely one part of the answer, but it doesn't, to me, get to the core of the mechanisms of the power structure. The roots, the causes. So maybe if you can reflect on some of the lessons from the Sundarban region in thinking through this question about
Okay.
about it.
I would just like to respond to your question that in India there are definitely they are the shadow patriarchy. Yeah, they are barrier of the patriarchy. The thing is that to start with, I think it's a good start. There is an issue of acceptability. Once these ladies who are in the panchayats now, they start understanding their importance in this policy making or in decision making, they will certainly change their role. That's my hope. So to start with, I think it's a good way to begin with. Regarding my lessons from this intersectionality analysis, I will again say that the vulnerability is multidimensional. So it's no way a good step to drop down to just a single dimension and easy blanket approach or solution, a single solution for a very complex issue like this. So we really need to think vulnerability by using intersectionality lens. So it can definitely then bring practical solution, and that's going to be sustainable with the community.
Okay, so essentially there's no magic bullet, and we need to ask more deeper questions, not looking always for the answers, but to really explore more deeply.
Yes,
Thank you for sharing your experience. It was lovely
pleasure.
chatting with you. Okay.
Pleasure.
Oh, so good, guys.
Did you delete it?
Don't say that.